see a full room. Pleased that everyone is here for our update on global mental health at DGHI. So I'll tell you how this will proceed. We've selected 4 faculty members to tell you about what they're doing. Some of this is in process. I don't know who's got data, who's got pictures. Eric's got video, of course, so we're ready. So let me just start by asking, who's a student in here? Keep your hand up if you're an undergrad. Technically a student registered at Duke, let me put it that way. Undergrads, master's students, PhD, postdocs, faculty members. Anybody who has not raised their hand? Okay. Sorry, staff. My error. All right. So, and Anita is our guest. Did you raise your hand as a DGHI faculty member? Okay, you should have. So anyway, thanks to everyone. I'm really pleased to have the presenters as Noel Baumgartner. Second will be Rae Jean Proeschold-Bell, followed by Eric Green and Liz Turner. So they're going to talk to about 7 minutes, and then if they're going much past that, I'll get up and stop them, so that we have a good amount of time after that for all of you to ask questions, because the idea is to tell you what we're doing, talk about where we might be going, how you might be involved, and hopefully everyone can see. I've been told that that most of you can see from your spot. So there are places in the front, and then when everyone's done speaking, they'll move up to this table and we'll have much more of a conversation. Okay? All right. Ready, Jono? Sure. Good. I'm Kathy Sikkema, by the way. Sorry. I run the Global Mental Health Initiative panel. Sorry.
All right, so I'm talking about adapting evidence-based psychosocial treatments for psychoses in Tanzania. So to get us started, in case you're not familiar, schizophrenia is a severe mental disorder affecting about 21 million people worldwide, and that's about a 1% lifetime prevalence globally. It's characterized by distortions in thinking, perception, emotions, language, sense of self and behavior, and that sort of manifests in hallucinations, delusions, and abnormal behaviors. There's significant stigma with severe mental disorders, particularly schizophrenia. Discrimination and violations against their human rights is commonplace, but it is treatable, usually through some sort of combination of medications and psychosocial supports and treatments, including things like assisted living, supportive housing, and supported employment. And just a few years ago, World Mental Health Day focused on schizophrenia, which was really exciting to get some more attention paid to schizophrenia on a global level. So there is, as you probably know, a mental health treatment gap in lower middle income countries. The burden of psychotic disorders, and when I say psychotic disorders, that's inclusive of schizophrenia, schizoaffective, bipolar with psychotic features. It's the burden, the prevalence numbers are actually fairly similar in lower and middle income countries as they are in high income countries. There's just a lot less services and attention paid to it. So, and as I stated earlier, it's treatable, usually through a combination of medication and psychosocial related treatments. But there's a real absence of evidence-based psychosocial treatments for individuals with psychotic disorders that have been tested in lower and middle income countries. And in particular for populations where resources are really scarce, right? Families are much more fundamental in treatment. I can give an example. So in Tanzania, if you wanted to be admitted into a psychiatric hospital, you actually can't be admitted without a family member. And you also can't be discharged without a family member. They very much see treatment as a family intervention and not people totally on their own. This also has issues related to privacy and confidentiality. That doesn't exist. Why would they want to do that? They want to work with the whole family. That's sort of the given. And then also in a lot of these areas, affected individuals and their family members hold non-biomedical ideas about the causes of psychosis, and therefore they're seeking treatment from more traditional practitioners who they think are the right match for the type of treatment that they need. So there are actually in the US and in Europe a lot of evidence-based psychosocial treatments that are beneficial for folks with psychotic disorders. One of them is called family psychoeducation. It's a very specific type of psychoeducation. It's an evidence-based practice that's been developed in high-income countries and has been shown to reduce hospitalization, relapse, and improving functional outcomes and recovery goals that the affected individual themselves has identified. FPE includes individuals plus their family members in a multiple family group setting. And there's just a bunch of sessions. These are some of the topics that they talk about. There's a lot of education about the illness, problem solving, just the support of actually being in a group setting. And the format of it is these joining sessions that are with the provider matched with the individual and their family member that are a little more individually tailored. Then they join these larger groups, and it's a very structured curriculum, and the content is very structured in it. And then those sessions usually go for 3 months, 6 months, and sometimes up to a year, depending on the model that's being tested. But they're not sort of generic support groups in any way. They are very structured in the types of content that's delivered and the strategies for problem solving family by family. But there is limited evidence on how family psychoeducation can work in a lower middle income setting. And there have been a few studies out there that show that greater education about illness has actually increased familial burden if culture is not taken into account. So in Malawi, for example, they actually tried to do family psychoeducation. They published their beginning formative papers and then found that they were making things worse for the individuals and the families. And so that was an issue of taking something that hadn't been adapted, saying it's evidence-based, plopping it into another country, and it was not having the intended outcomes. There's also some unpublished literature about the same thing happening in South Africa. So basically pointing towards, if you've got an evidence-based practice in a high-income country, no assumptions about how well it will work elsewhere. So in the US, the SAMHSA, the Substance Abuse and
Mental Health Services Association.
That's right. They have on their website, open and publicly available, like a set of the evidence-based psychosocial interventions. Family psychoeducation is one of them. So this was our building block. It's quite generic. And so what we're going to do is adapt it. So in Tanzania, the team that I work with is with Muhimbili University of Health and Allied Sciences in Dar es Salaam, Tanzania. It's been renamed as Kupa, which means to soar. We need another picture of a bird that's actually soaring. I haven't got that yet. But the idea is that we're developing and testing a culturally tailored model of family psychoeducation for adults with psychotic disorders and their families. It's an R34 mechanism, which is 3 years. And it's to develop, culturally tailor, adapt in preparation for an eventual R01. We are working in Dar es Salaam, which is, I'd say, the commercial capital. It is not the political capital. And in Mbeya, which is in southern Tanzania. We have almost finished up phase 1, which is the formative research, which is a ton of qualitative interviews with stakeholders. But the other phases of the research will include actually coming up with a new Kupa manual of family psychoeducation, and then doing a pilot effectiveness study, randomizing individuals and family members. So, adaptation, which is what I was supposed to be speaking about today, has a lot of different pieces to it, and I've got to sit down in 1 minute. It's got a local review panel, it's got an expert review panel, which are sort of global experts in family psychoeducation. We have to make sure that there's some fidelity to the original family psychoeducation model, and then we're going to do like a open case group before we move into like the real cases that would be part of the pilot effectiveness. And then all the qualitative data is feeding into the different elements of adaptation, and there's a lot to take into consideration. We're almost done with data collection. We've been talking to a lot of individuals with psychotic disorders, potential beneficiaries themselves, including caregivers, clinic-based providers, a bunch of alternative or traditional practitioners, and these are folks identified by the patients themselves as people that they seek out for treatment, as well as health managers and government officials. So really quickly, just I'll end on a couple of quotes. The first is, how different are the services provided by traditional practitioners and spiritual services in comparison to the hospital-based services? And this particular outpatient said, the difference is the providers at the hospital tend to monopolize the services so as to look more important than alternative practitioners. In fact, all of them are important. So, and they've already made a judgment about like how much they might be willing to share with their clinic-based provider, right? And one of the things that we want to do in this family psychoeducation model is pay attention to, acknowledge, respect. As long as no harm is being done, how can we incorporate in those traditional practices and services so that they can speak freely and openly with their clinic-based providers too, especially if they're doing dual treatment, which is one of the end goals, is just at least being able to talk openly and honestly about what they're doing. I won't say this whole one, but it's another one about this issue of dual treatment, and this is from an alternative provider, who at the end of it is saying, you guys do all your stuff, but what we do is we operate by using our culture. And at the end of it, this particular person was quite open in saying, but if you want to win in these problems, we all should come together and not just criticize the witchcrafts. It's real and it's there. So, I mean, there was a real openness to collaboration, and then part of what we're trying to do is like, how can we figure that out? The actual detailed logistics of the collaboration instead of just talking about it. And then family psychoeducation also talks about family, the environment, and the social stuff. But this is an example of a problem-solving thing that they could talk about in the groups. Here's a family member saying, are there ways you could support your family member that you're not able to do? And she said, yes, there's things I wish to support, taking her for an outing, change the home environment. It could assist her to recover when she's in a new environment, but financial capability is the problem, which makes me feel to do that. So that's actually a great example of a problem-solving thing that could be dealt with within the family psychoeducation groups, and other family members could help her figure out a way of supporting her daughter. And then also the issue of community support. How is community support different from family support? I think they're all equal, because sometimes you stay at home alone with only tenants. Do the tenants support you? Yes, they support me. And sometimes if they're slow, they give me, because sometimes I'm not able to cook. And this is something else that other families in the same group could potentially benefit from, like what are some strategies of reaching out to your community to sort of help your affected individual who needs more. There is no safety net, right? There are no disability benefits. There's nothing except for family and community. And so coming up with strategies to figure out how to support them to live in the community is important. It's a huge team, lots of collaborators. They're all super awesome. I think that's my 7 minutes. So thank you.
Hey everybody, I'm Rae Jean Proeschold-Bell, and I'm excited today to tell you about the Caregiver Flourishing Project. So this was kind of unusual. I'm funded by the John F. Templeton Foundation, and their call for proposal said that every proposal had to have a psychologist and a philosopher. So my philosopher is Warren Kinghorn, who is a theologian with an appointment in Duke Divinity School, but also is a psychiatrist. And here are our research questions. How do caregivers who work in the context of suffering, here the philosophy enter in, sustain emotional engagement, derive satisfaction, and maintain high positive mental health? And we've been working in five different sites: Ethiopia, Kenya, Cambodia, and I just want to say the 2 places in India are rather distinct. Hyderabad and Nagaland are culturally quite different, with Nagaland over there near Myanmar. The only way that we were able to do this in this 22-month grant is by partnering with Kate Wetton, who has been working in these sites for 11 or 12 years now through the Positive Outcomes for Orphan study. And each of these sites has their own NGO leader, site PI, very well-established and high-quality research teams who I thank deeply here. And just to say a little bit about the children, these are the children that the caregivers would be taking care of, and actual pictures from our study. And the children themselves, most of them are over age 5. They've all, of course, had the trauma of being separated from both their parents in this case, because we're only talking about caregivers who are working in institutions, and more than half have experienced 4 or more traumas. But we're looking at the caregivers, and we're looking at what's going well, and one of the things that we're interested in is their religion. It's interesting in stress models, you know, people will give a nod to religion playing a role in coping with stressful circumstances, but it's not very nuanced yet in the literature. And it's very exciting here, the religious diversity that we've got across the sites. if you take nothing away from today, I hope that, or from my talk of today, I hope that you'll think about positive mental health. When you're doing your own research on global mental health later, perhaps you'll apply this concept, which really comes from Corey Keyes and Carol Riff and other people, but it's distinct from the absence of mental illness. Like the absence of depression is different from having the presence of positive mental health. And this is conceptualized as experiencing positive emotions on a daily basis, as well as functioning well in two areas. So individually, this is like having meaning in your life, feeling like you have opportunities to grow as a person. But socially, it's also feeling like you belong somewhere and that you can make a difference in this world. If you have high levels of all of these, then you have high positive mental health. And we were interested in particular in the caregivers of orphaned and vulnerable children who have high positive mental health. And we hypothesized, again, the stress models out there are pretty basic, and we've added to them. So the stressor in our case is caregivers caring for children who've had these difficult circumstances. That's pretty common to look at. And then all the psychological stress appraisal models say the next thing that matters is you as an individual, in our case the caregiver. How do you make sense of your stressors and what do you think about them? Because we don't always find the same things stressful. One of you finds an exam far more stressful than someone else. And what we are thinking, and what some other literature is suggesting, is that when your stressor is deeply meaningful to you, that you don't experience it as a stressor nearly in the same way. You're contributing to the world. And so we think religious beliefs might play a role in this. Even if you think that what you're doing, like caring for these children and launching them to be successful in the world, is important, you still might have to cope with it being difficult. We heard a lot about difficult behaviors for children, for example. And here's where my philosophy partner enters in. He's really interested in virtue and virtuous practices. I've learned along the way that a virtuous practice is a habit that's good for you and the community. And so, again, we think religious practices might play a role in here. And while most stress models care about reducing stress symptoms or burnout at the end, we're also caring about who results in having high positive mental health. So, we have completed our data collection. It's a mixed method study. We've also done surveys, which aren't listed up here, but we interviewed the directors, and I want to give a shout out to Blaine Biru, who I thought I saw here, who did a couple of the director interviews in Ethiopia and has been analyzing the do interviews and successfully defended her thesis on those. We also have done in-depth interviews with 69 caregivers and got diary data from them. Believe it or not, they wrote down what they did every half hour of the day for 7 days with emotion data along with it. So we are 1 year and 7 months in. We've got 3 months to go. It's a super short grant. I'm going to highlight just a little bit of our findings from the caregiver interviews. And so the first thing that we've really been looking at is, for those with the highest positive mental health, what do they talk about that they're doing in their lives in general? And they name 6 things. These are roughly in order of how much they talk, either the frequency or the detail and importance that the caregivers gave it. And the first one was religious practices, which I think has an interesting implication in that I don't know that the literature on caregiving in general puts enough emphasis on that. The second one was to prevent burnout, the caregivers actually hunker down and spend more time caregiving. And then social support, which you would totally expect, talking both to other caregivers, their directors, and family members. Fourth came pleasurable activities, a lot of watching TV, streaming shows through Facebook in Cambodia, for example. Emotion regulation, which is when you've had a difficult day, handling that somehow. Or when you're having difficult moments with the children, like behavior issues, taking some time right then and there to calm yourself. And then the last, and this was far less frequently named, although it did come up at all 5 sites, so I wanted to bring it up, was removing yourself from your work, spoiling yourself, getting away. And so, in my last slide, I think there are a number of implications here that I can't wait to think more about. The first one is, religion may be underemphasized in the literature, and how can religious practices be brought in thoughtfully, carefully, in a community-based way into the institutions. Many already are religiously based, but not all of them. And can you have diverse religions, caregivers of diverse religions? The second is this idea of spending more time caregiving. I'm really excited about that. And at first I was a little baffled by it, and then it suddenly made sense. We looked at the diary data, and the caregivers spend so much of their time doing laundry, cleaning, waking the kids up, putting them to bed. Like, it starts to sound like my life as a parent. That what they really, the one way to prevent burnout is to spend time playing with the children and telling stories. There's a lot of telling stories came out. And then finally, let's see, the social support, we weren't at all surprised by. Oh, I think that some of these, if you're a director of an institution, it's really pretty heartening that you don't have to send your caregivers away to prevent burnout, that they can either play with the children on site in maybe some more regular ways, or some of these pleasurable activities they can do on their own. So I look forward to comments later. Where did it go? I don't know.
I'm here. Oh, just can you see it? It was just like,
So much for this being seamless, huh?
There we go. There he is.
So I just really took those steps. So
Okay. Great. Hi, everybody. Eric Green. I'm going to talk to you about a new line of work today to expand access to mental health treatment using phone-based chatbots. So you're likely familiar with the challenge that we're trying to solve. Too many people who need mental health treatment don't have access to services. So one strategy for closing this gap is to train non-professionals to deliver basic evidence-based interventions. And this is called task sharing. Research shows that task sharing can be effective, but there are barriers to scale up. Largely humans. We're difficult. We need to spend our time doing things that earn an income. Sometimes we live far away from each other and we need to travel to meet up with each other. And when we're not monitored, we can get off message, particularly if we're lower skilled and newer to it. So we need help, and computers can be humans' new best friends, I think. And my team isn't alone in thinking this. Advocates of task sharing often talk about a role for technology, and the tech sector is quickly realizing that they have something to offer and maybe also something to gain. In the past few years, we've seen a number of headlines that have been very chatbot-like produced to say that chatbot will see you now. This is Wobot, your charming robot friend. Let me show you how it works. Video should pop up, and what you're going to see is me signing up for the service. Request access. Oh no.
oh, you're probably gonna have to sign into your own Google account.
Okay. Well, I don't think that will work, actually.
How great that password's grayed out, huh?
Because technology, my point is, can really help us to solve problems. All right, let's do this. So, this is me signing up for Wobot. They have an app. So this is one version that uses an app. You can also use Facebook Messenger. I'm going to show you SMS later. So this is in the Wobot app. I'm getting started. It's in the beginning telling me it's not a human, and it's telling me how I can respond. And when you have app-based services, they let you have some new features where you can just click along on the bottom to really easily keep the conversation moving, right? So it's telling me that, again, it's a robot. It's going to use CBT, asking me if I know about what CBT is, and it's telling me it works by signs. And what I'm going to show you now is me coming back later asking Wobot for a check-in. Like, I'm not feeling all that great, what Wobot is going to do is ask me how I'm feeling and check in to see if I want to go through a CBT, a cognitive behavioral therapy module. And this is really where Wobot shines, is then helping me to walk through some of this structured material. Available 24/7. So let me see if I can. So this is some of Wobot's features, right? Tracking your mood, giving you some insight, teaching you things, and the creators do bill it as a treatment, not an adjunct to treatment, but a treatment in itself. And the creator of Wobot is a clinical psychologist and really talks about the role of computers in CBT. That, you know, the therapist shouldn't be the center of this anyway, so we can probably structure this in a way that computers could be helpful. They did a randomized trial of 70 college students, and college students either got Wobot or they got just a link to download some mental health resources. So they weren't really comparing it to much, but they did find about almost a 20% reduction in depression symptoms among college students in the US using Wobot. Another company is X2 AI. This is the company we're partnering with in the project I'm going to tell you about. They found, interestingly, a pretty similar effect size in terms of reducing depression and anxiety among college students, again, in the US. It works in a similar way. This is Sarah. So Sarah, this is on Facebook Messenger. And I went through last night and started talking with Sarah. So I showed you an app, and this is within Messenger itself. You know, so Sarah is also going to tell me that she's not a human, right? So I know that I'm interacting with a machine and not a human here. And she's trained by psychologists. The folks at X2 are psychologists, and they've built Sarah along the same CBT principles. And Sarah's going to take me through a Q&A session. We're a little behind because of our snafu, so I'll just jump ahead. You get a sense. I want you to at least have a sense of what these apps look like in practice. So what we're going to do is we're working with X2, the last version that I showed you, to adapt a program for perinatal depression called Thinking Healthy. This is a CBT-based program developed in Pakistan, showing really good results and delivered through lay health workers, right? And what we're going to try to do, because it's CBT and it's very structured, to be able to adapt the content for delivery over SMS and interactive voice response. So we're not going to be using Facebook Messenger or a smartphone app, because most of our users are going to be people with just basic phones and only access to SMS. So we'll take the very structured Thinking Healthy program, and it goes through certain tasks of, you know, reviewing content from the last session, going over your mood chart, going over some activities. CBT is very homework-oriented and practice-oriented. So right now, our BAS team is taking all of the content in the Thinking Healthy module and turning it into SMS bite-sized chunks that we can deliver. So we're going to take 20 women from Nairobi this summer, and who are greater than their third trimester or a little bit later of pregnancy. We're going to do a single case experimental design and looking at feasibility and acceptability. So basically, when women are using this service, you know, are they able to get through it? Do they stay engaged? Are they finding it helpful? We want all of this to design, help inform the design of a future trial. And this is mock data. Something like we might be looking at staggering women as they enter the trial. This is kind of typical of an N-of-1 trial where people overline in their baseline periods is what you see before the red line here. And basically you look to see that they're stable, they have these symptoms before the treatment, and then they enter treatment and their symptoms reduce. And we're working with Jacaranda Health, which is a maternity health hospital in Nairobi, founded by Nick Pearson, who's an adjunct faculty member here at the Institute. And we're working directly with X2, this AI company in Mountain View, to, once we get our content adapted, to be able to plug it into the test software and use that to deliver the program to women in Nairobi. Thanks.
Okay, so I'm going to just talk about two broad designs to give a little overview of some what might be recent developments for some of you. So first I'll start with an individually randomized design, and actually it could be quite applicable to Eric's setting if we thought of different elements of delivery of the WOBOT. So let's just say we're trying to optimize the delivery characteristics of a community health worker delivered one-on-one behavioral intervention for depression. So this is inspired by real studies, but I'm just going to keep it sort of general. So a solution could be to use what's called a factorial trial, and they have different versions. I'm going to first talk about the full, and after this brief intro, I'll talk kind of overview, I'll talk about a cluster randomized trial design as well. So suppose we had this is a multi-component behavioral intervention, and there's delivery factors. So there might be 3 of them: the frequency at which you give these one-on-one sessions, the duration of the whole program, and the location where you do this. So for example, there might be 2 levels of frequency, once a week, twice a week. The duration might be, say, 6 weeks in total versus 4 weeks, so that would change the total number of sessions, depending on the combinations there. And it could be in the home or clinic, say, with a community health worker. So here we have 3, you'll see why I have this structure in a moment, 3 binary intervention delivery factors here, each have 2 levels. And then overall, there's 3 of them, so there are 8 possible combinations of each of these 3 factors, because they have 2 levels each. So we call these 8 conditions. So this is a full factorial randomized design, and it's specifically called a 2 to the 3, because there are 3 factors and each have 2 levels. So this is a bit of kind of the notation, just so you know. So let's suppose, it's a bit weird, the bottom here. I don't know if we can get rid of this. So you're just going to have to bear with me with this appearing at the bottom. So let's suppose we randomize 160 participants, so there'd be 20 on average in each of the conditions. There are 8 conditions. You might think 20 is not very many in each condition, but 160 doesn't sound too bad. So we'll keep thinking about this along the way. So now keep in mind we have 20 people in each condition. So each of the once a week, there are 4 conditions there. So we'll actually have 80 individuals who are observed under once a week of this therapy. And then we'll have 80 individuals who are observed in total under having this twice per week. So half of the individuals once a week, half twice a week. And then there's a range of the other factors that they'll be observed under. So what happens is, the really neat thing about this design is you get a lot of information about the overall effect of having this once per week versus twice per week, using information from the 80 people that are randomized into one of those 4 first conditions, and the 80 people who happen to have been randomized to these here. So you actually may end up having more information than you might anticipate, even though there were 20 people in just each of these conditions. So we're trying to get information about all 3 of these factors and possible kind of interactions, so how they might have some synergy between them. So that's the beauty of this kind of design. So for example, here, as I've just said, we'll use information from the 80 people versus 80 people to give us information about the importance of the frequency of this delivery. Now, you might say, well, I don't really think I can even conduct all of these 8 conditions. I have some constraints in the system, human resources. So you can start looking at more specific versions of this, where maybe you just consider 4 of these conditions. So this is called a fractional factorial design. So this is another kind of feature. This is particularly appealing too in the situation where you think there's not really going to be really high-level synergy between all 3 of these factors. So in this case, each of the factors now, factor levels, each appears twice. Twice once per week, and twice 2 per week, and Same for the other two factors there. So this is an example of a fractional factorial. Okay, so wrapping up this piece, this kind of framework you can optimize. Optimize kind of depends on your context. You have to work with a team to define what it means to optimize these components. You can optimize under cost constraints, so it's not just due to statistical constraints. And what's very interesting about this is it fits within a larger framework that's getting a lot more traction in developing interventions. It's called the multi-phase optimization strategy, MOST. This is one component of it. It's typically used as kind of design, a fractional randomized trial, randomized controlled trial. And we were actually introduced to it at the call by Gary Bennett, who has an ongoing R01 in obesity research, and recently Bonnie and I, with other colleagues in the research design and analysis pod that I lead, we've been talking more about how to use this and apply this in global mental health. So there's a lot of promise, I think. Okay, now in the second half, many of you know I love Eat, Sleep and Breathe plus the randomized controlled trial, so I was bound to talk about this. So let's suppose that we now want to roll out a community implementation of this one-on-one intervention. But we have this constraint that we're only going to get the communities on board if they know eventually individuals who need this intervention are going to get it in their community. And secondly, we can't roll out to all of the communities. We're going to imagine we have 8 communities in our study. We need to have some staggering of these, of the rollout. So a possible solution is this new hot design, well, fairly new, stepped wedge cluster randomized trial. So let's just look at it visually. Let's suppose we have 8 communities, so like 8 villages, say, and we measure them all, say, at the baseline period. So this is not a step wedge design. And then we've randomized half of the communities to receive the intervention and half to receive control. So let's say 1 year later, everybody in those randomized to intervention, all of the individuals in that community have received this who needed it. They've received this one-on-one behavioral intervention. And a year later, we go back and we're able to measure their kind of depression status, and we also measure that within the communities that were randomized to control. So this is the standard parallel arm cluster randomized control trial, and we happen to have a baseline measurement of the outcome here. So these represent communities, and there are individuals measured within the communities. Now we said we want staggered rollout, and all communities get this intervention by the end of the study period. So we still have the same total number of measurements in the communities here, but you see now that all of the blues, all communities eventually become green, so we see them both under the control condition and the intervention condition. But what's more, we've randomized the start time when we start measuring each of these 8 communities. So there's still randomization in there. We have this staggered rollout, different start times. Now we've extended the whole study follow-up period. And we have the stepping. You see the step wedge is the stepped feature here of where the blues go to green. So this is kind of your sort of very pared down step wedge cluster randomized control trial. And in this case, it has some terminology that goes to it. It's incomplete because we don't measure all clusters at all time points. But we still have the same total number of measurements, although we've had to conduct the study over a longer period, so you can see that could have drawbacks to it as well. Now, if we filled everything in and measured all of these clusters at all time points, we have a lot more information, so it can give you a lot more power. But it's a lot more burden on those who are collecting the data, on the participants. I mean, this could just be prohibitive to do this, but it still fits the constraints. But maybe if you're no longer giving support for the intervention, it might be in this kind of sort of post-intervention period. It might still be kind of being implemented, but not at full scale. You might kind of need to take that into account when you analyze data from this. So, the last little piece of information to kind of help think, where's all of the information about estimating the treatment effect coming from? So in a standard parallel cluster trial, you mainly use vertical information, so between cluster information, to estimate the treatment effect. Over here, let's just stick with the complete design so we can see this more cleanly visually. You still have between cluster information because at the same time point you have both control and intervention clusters, so you can use that vertical information as well. But you have a lot more here of this horizontal, so within cluster information, where you see every cluster both under control and then under intervention. So you've got a lot more kind of information you can use to draw on here. Yes, we can use within cluster information here because we've got a baseline measurement, but we have a lot less information overall. So Overall, though, the challenge here is, on average, the control periods are earlier than the intervention period, so you can have confounding by time. And this can be really challenging to take into account in the analysis and must be taken into account. So, just to kind of wrap up then, for statistical reasons, even though this is the hottest thing ever, even in the statistical community, for statistical reasons, you should still try to stick to the design on the left for you, the parallel design. Even though I want to do one of these, I don't want to do it for statistical like for the inference we can make about the intervention effects. But at least if you were able to randomize and you had all these constraints, the step wedge design is still better than not randomizing and can still give you a lot of interesting information. So there's loads of work going on in statistics now. I mentioned this, that you have to account for the possible confounding effect of time in these step wedge designs. And the great thing is it is kind of a pragmatic design and can be pretty appealing to communities. So you can see why in practice these can be quite attractive to community members. They also exist for individually randomized control trials and very related to the multiple baseline design that Eric mentioned. And Rae Jean and I have actually collaborated on a trial that Rae Jean led, which was an individually randomized step wedge design. So there's loads more going on in trial designs today. Smart, sequential, multiple adaptive randomized trials, N of 1 trials like you mentioned. A lot more interest in not just saying a thing's better, are they equivalent, not inferior, and big movement to formalize pilot and feasibility trials these days, which I think is a much needed kind of step. There's even a consult statement now on reporting of pilot and feasibility trials, which is really, really great. So that wraps up for that one, and thanks so much. Are we all going to come up?
Joy Noel. Goodbye. I think Joy Noel's been back from Tanzania for less than 24 hours. Cameroon, sorry. All right, thank you, everyone. I hope this snapshot makes clear to all of you that the snapshot of what's going on in global mental health research at DGHI ranges in methods used, qualitative, cluster randomized trials, to artificial intelligence, and with various projects at different phases. So I have a few things that I can certainly ask the group, but I'd much rather allow you to ask either specific questions about projects or thoughts about future. So any questions or comments? Yes.
I had a question related to Dr. Green's project on AI. I wasn't sure what's the data and the literature on the treatment effect of clinician treatment to patients, and if so, are we seeing that the AI treatment is becoming comparable to that? So,
I told you the Think Healthy program was developed in Pakistan, right? And they saw pretty big effects, right? Kind of reducing depression symptoms in half. And that's bigger than what I showed you, the 2 trials among college students using these chatbots. But to me, even a 20% reduction using an automated platform that costs basically nothing to roll out can be meaningful. You know, we don't have to look at an apples-to-apples comparison in effect sizes. So it can be weaker than an in-person, which is what you totally would expect. I would be very skeptical if the computers were doing much better than the humans. But the real problem is getting people in front of community health workers in the first place. So there's a role to play, I think, for the artificial intelligence platforms. And if they have some effect, then it's better than nothing. We're trying to expand the reach, the access to care.
I had a question somewhat related to that, also for Dr. Green. So in regards to the topic of chatbots, sometimes I use Tinder, which is like an online dating application, and I will engage in a conversation, and then I'll realize that this is an actual robot talking to me for my credit card information, and I'll feel disappointed about this human interaction. And I'm wondering, do you think that the future of chatbot therapy might involve chatbot therapists who don't disclose their identity? Because I noticed that in the design that you mentioned, they do list that they are an AI therapists. And I wonder whether the efficacy of that kind of treatment might be improved if, in fact, the patient or whoever it is doesn't know.
Yeah, there was a study recently that showed there was no difference in outcomes whether they were told that it was a real person or a computer.
Oh wow!
But Woebot won't swipe left on you, or just swipe right.
Unconditional regard.
Now I have another question for Eric. The phone-based intervention you're doing, how lengthy are the responses that the users are going to be putting into this thing?
So,
Just repeat that in case people.
I'm sorry.
yeah, how lengthy would the responses be? That's one thing we're going to be looking at this summer because up till now, these companies have been putting it on smartphones with apps with built-in like virtual keyboards, right? Our users, some of them will be using candy bar style phones where you have to hit the number 1 button 3 times to get a C. So we think for some subset of users, our responses are going to be much shorter. So we're building it much more directional. So asking yes or no questions to move someone through a particular pathway, rather than very open-ended, how are you feeling today at every point, where they'd have to put in a long sentence every time. So we think we'll get shorter responses.
I have a question for Joy Noel on I think it's wonderful to try out this family-based intervention. And I was wondering whether there might be something that kind of influences whether it's working or not related to what is seen to be the cause of the condition. So if the cause of the condition is something to do with witchcraft, you might want to keep it more secret. So then a one-on-one or a kind of someone you trust with a traditional health professional would be more sought for, and the family-based would be seen to be risky because it might be someone in the family.
Yeah, no,
who
that's
is bewitching
interesting.
you. So I was wondering whether you can add in some kind
So
of...
the secrecy part is them keeping it secret from the clinic-based providers. They actually have no problems disclosing if they think the source is witchcraft to family, friends, and communities.
Is that what you're finding?
Yeah, and I've done dissertation research on this like 15 years ago, and that was the biggest barrier with the clinic-based providers. So it definitely could be a family member that's the cause of the curse or whatever that needs to be addressed, and we're totally open to that. If they want to be doing some sort of additional rituals to figure out a way for people to, for the family to have additional harmony and that sort of thing.
That can be integrated.
All of that's up for grabs. The only stuff that is excluded is things that's physically harmful to the person. So we find no reason, and neither do any of the psychiatrists in Tanzania, and they're the ones that I work very closely with them. They're the ones that came up, we agreed jointly that family psychoeducation was the model and that it should be very family oriented. Dr. Sylvia Kaya is my partner in crime on all of our mental health research, and so the main issue was the providers know and acknowledge and sort of sometimes accept the traditional treatments, but they need a standardized way of figuring out how to incorporate it and talk about it, so that they are not further stigmatizing and causing folks not to follow up and talk about what other, like maybe there's a ritual that needs to be done, maybe there needs to be some sort of broader family meeting, maybe, you know what I mean, like there's other stuff, and they would like to be a part of that, but there's a lot of fear that talking about it in a clinic, they'll be judged for doing that, even though all the providers know that it's happening.
Yeah.
So that's the secrecy element.
Okay.
Yeah, it's really fascinating and interesting. Yeah, yeah.
Other questions?
So I have a question for Dr. Baumgartner and questions for the positive for Dr. Rae. I'm wondering, with the Tanzania study, do you think physicians are willing to work with traditional or, traditional healers within that community? So that was my question for that. And for the positive mental health study, I'm wondering, the people who launched the request for proposals, how would the data be used, and Within one setting, I'm wondering if the data would be to help, give advice to the the people who take care of the orphans. I'm just wondering, what are the next steps? Yeah.
So the quick answer is yes, the clinic-based folks are interested if they sort of know how to, like they want that additional guidance about it, and vice versa also. So far the traditional practitioners are also open to it, because for the most part, even though they might have a specialization in mental health, and we saw this in work in South Africa too, they don't know how to collaborate with the clinic-based providers. Like they'd like a shortcut on referrals, for example, or to have like a extra connection, or like, how do they write a referral? They're like, okay, this is outside of what I can help with. How can I help them get to a clinic? They're not, if they're not recognized as a provider. So it's the actual logistics of how to collaborate is part of what they want to figure out. But there's definitely an openness to it on both sides, because the truth is there's no perfect 100% treatment even in the clinics, right? So they are open to a more holistic way of treating and caring for their clients.
Dissemination is such a good question. Like, this is an exciting study for me because it is very applied. Like that was really the whole point. There are these concepts like positive mental health that have been studied in the labs, and now we can bring it in under real world circumstances where it hasn't been studied before. So I do hope that we can get these findings out in terms of recommendations. Like what I was telling you today is pretty specific, and we have a few others. We're going to rely in part on the NGOs that we're partnering with in each of those countries, and to create brief statements that they can give to the other child advocacy groups in the area, or the institutions, the orphanages and such that they work with. That's one. We are going to be doing a webinar this summer with CAFO. It's the Christian Alliance for Orphans. It's a U.S. group that encourages churches here to contribute to orphanages and institutions around the world. So that's another thing that we'll be doing. Kate Weckman has kind of a love-hate relationship with UNICEF, but we still hope to maybe have a one-pager that we would promote to UNICEF. And then in May, I get to meet with the other grantees, and I can't wait to hear what the philosophers think. It was so fun when we had our grantee meeting a year ago. The philosophers were like, there are 5 paths to well-being. Wow, that is so specific. You've had 1,000 years, and you've got 5 paths. Are you excited that it's only 5, that you've narrowed it down, or should you have 20? Like, I don't know. Anyway, it'll be fun to get their reactions. Go ahead, Bonnie.
Rae Jean, I have a couple of questions. One is the finding that you brought up that was surprising about them saying like they do more caregiving as a coping strategy. But when you describe what they're talking about as the alternatives, it kind of all strikes me as caregiving, like laundry and making food is caregiving. And I'm wondering if they actually described it as like, this is actually not my job versus like interacting with the kids is, or if it's just kind of like the interpersonal part of caregiving and it's more enjoyable, like how you sort of make sense of that. And the other is just a quick question about if you've done any measurement of positive mental health in these kind of comparative sites and how you adapted or kind of worked through the idea of making those comparable, I guess.
Those are both really good questions because we are in the 5 different sites. So I think I was the one using the label caregiving to keep this within 7 minutes, but it's hard to be so specific. No, I think that they see their work as their work. About 3/4 of the caregivers we interviewed live on site, and they'll either reside there for months at a time, or for 4 or 5 nights a week. So for them, this is pretty much their life, and so they were not describing it as caregiving or not. And I think they all find it to be work, but many of them also find it to be some kind of a calling. They didn't really use, that would be my term, calling, but they would talk about their most meaningful moments being when children would come back with a really good test score, or when they saw someone who used to fight a lot no longer fight with the other children. So I think they were talking more about their pleasurable moments as opposed to their less pleasurable moments, all within this kind of work context. As for the positive mental health measure, oh my goodness. So Corey Keyes, who is a co-investigator on our project, and we're really lucky to have him, he developed this 14-item measure called the Mental Health Continuum short form, and he's had other colleagues using it all around the world. Nevertheless, I was still skeptical because, lots of different cultural contexts. So what we did in terms of translation and such of the measures is Corey and I met with the researchers at each site over WebEx, Skype actually, and didn't just have them translate it word for word, but had Corey talk through the concept. So his positive emotion questions are, how often did you feel happy, interested, satisfied with life? So they would have like a whole conversation around what satisfied with life means. And then they would try to translate that concept. We did do the back and forth translation, but I think this other thing was the more important step. And then we were able to kind of look at, I will say, most of the caregivers scored really high on positive mental health. That was somewhat of a surprise. But in hindsight, our recruitment, our selection, we required that all the caregivers be considered good caregivers by their supervisors. Because I didn't want to know how people were promoting their positive mental health if they weren't good. We all could just go goof off all day. And that's not who we wanted to study. So consequently, and unfortunately really for me in the study, we don't have a lot of burned out or low mental health caregivers to compare to. But the highest positive mental health scores do hinge on what they said they were doing during the day and their emotions during the day, which gives me some more confidence in that measure. Although it was a lot of work to collect diary data.
Thanks, Rae Jean. Melissa, you have 1 minute. You want that? No? Yeah. Okay, go ahead. Take the last question.
Dr. Green, how does the bot respond to very serious threats like suicide or murder?
So you set, in the platform, you set crisis alerts, and it can hand off to humans. So you can have, you can have like a hotline, essentially, and have humans be ready to take over conversations when crisis words are triggered.
Okay. And it picks up on subtleties, like indirect ways of saying that you're going to commit suicide or murder?
The way all this works is it's better the more volume it has. So the more conversations it has, the more times human counselors are there to say, yeah, this was actually a problem when they said it this way. Over thousands and thousands of interactions, the machine gets better at identifying, words that aren't so explicit, right? Phrases that aren't so explicit. But it's kind of like the safety hatch, so you can just move the person over seamlessly to a human. So again, the whole thing is not replacing humans. It's trying to make us all a little bit more efficient to be able to reach more people than is currently possible.
Thank you.
Thank you. Let me just thank the full panel for this range of topics and methodologies. And as I was listening to you, I was thinking maybe we somewhat intended this, but the 3 projects were described are quite preliminary and pilot, and we had Liz to give us the context for when we go big, where we're going to go. So that will be a conversation for the future as you take these projects to larger scale trials, hopefully. So thanks, everyone. Thanks for being here.